So once an ACL is ruptured, there's lots of comparisons. Should an athlete or should an individual, whether an athlete or not, have a reconstruction or should they not? And if so, which should they have? What can you tell us?
We've been doing in the last decade, that's where a lot of our work is focused. So where we went from there in that big county, those studies are, we just submitted another paper from that original cohort to a Journal of Athletic Training. So basically, what we showed was these neuromuscular imbalances put an athlete at risk of an ACL tear. And then we kept following the same athletes over time, over many years, decades, and basically followed those that went on to a second ACL tear. And then we had data from when they returned to sport. So we had measures of ligament dominance, trunk dominance, leg dominance, quad dominance on all these individuals when they returned back to sport. And we started looking at that. Okay, now what are the predictors of a second knee injury? And that's been a series of studies we also published in multiple journals, but primarily in the American Journal of Sports Medicine and Journal of Athletic Training. But basically, let's talk about risk for a second injury. In young active athletes, your risk of a second ACL injury is unacceptably high. If you're young, active, going back to the same sport at the same level, your risk of a second ACL injury is somewhere between 20 and 40%. That's as you can see, just unacceptably high. That's why we kept moving on with these studies, because we kept seeing these athletes being injured again and again. During these studies, our study team had 6 researchers on it with us at Children's Hospital that had had 2 ACL ruptures. The first ACL rupture is very, very difficult. The second ACL rupture is devastating in every way, physically, psychologically. So let's go back. Someone tears their ACL. Should they or should they not have it reconstructed? This is a controversial concept. I do not think, in my opinion, that someone should automatically have their anterior cruciate ligament reconstructed. So there were multiple studies out of the group that I was with originally at Cincinnati Sports Medicine that demonstrated what we termed the rule of thirds. Well, what do I mean by that? That study showed that about a third of people do not function well without an ACL, even when activities of daily living. That third of athletes should have their ACLs reconstructed. That means just with walking, you're going to have giving ways. If you're having giving ways with walking, you should have your ACL reconstructed. Now, there's a second third of individuals who can go back to activities of daily living and be fine without an ACL. They can actually function pretty well without an ACL. Now, that middle third is the difficult third, because you don't quite know whether you need that ACL reconstructed or not, because that leads into the third third, the top functioning third. About a third of individuals can go back to the same level of sport and function without an ACL. Now, there's a lot of discussion around whether that third should be reconstructed or not, because what many surgeons are going to tell you is, okay, they can go back and function, but they're going to end up tearing their meniscus. There's going to be too much motion in that joint, too many rotations going on without that ACL. On the flip side, I was in a group called the ACL study group. That was the top ACL surgeons in the world, about 150 of the top ACL surgeons in the world. There was more than a handful of those guys that I knew had ACL ruptures or bilateral ruptures who had no ACLs and never had them reconstructed. And these were the top ACL surgeons in the world. What that tells you is it is an option, especially if you can rehab your body in a way that is going to allow you to react and dissipate that force, as we've been talking about. Make yourself muscle dominant, make yourself symmetric, make yourself posterior chain dominant and core dominant, where you can control that joint before that load hits the ACL to a high level. So about a third of people theoretically can go back and play very high level sports without an ACL. And it happens all there's endless numbers of from John Elway on. There's at least a dozen players that have played at the high. We're talking Super Bowl MVP level people who played without ACLs and functioned very, very well. The other thing a surgeon might say is, well, if you don't get it reconstructed, you're going to have a lot of micromotion and end up with osteoarthritis in that joint. Here's what the data says. Kate Webster, who's based out of Melbourne, Australia, she's a world expert in systematic review, meta-analysis, has won a lot of the top world awards in that area. She and I recently just published a meta-analysis of all the meta-analyses that have been done in the literature regarding osteoarthritis after ACL. And we just published this last year. Basically, what you see is regardless of whether you have the ACL reconstructed, at about 10 years, you have about a third chance of osteoarthritis in the knee at 10 years. That's regardless. If you break it down and compare those who have had their ACLs reconstructed versus those who have not, there's actually a slightly but significantly higher risk, about a 7-8% higher risk of osteoarthritis in the surgically reconstructed knee than the non-reconstructed knee. So what is the surgeon's response going to be to that? Well, that's because that athlete was more active. You know, they're going further back. The group that's done most of the work there is based out of Sweden, and they basically showed that even if you control for activity levels, there is a slightly higher, though significantly higher, risk of osteoarthritis on a surgically reconstructed knee. So the answer should not be the reason to get an ACL is to prevent osteoarthritis. That is not the case. That's not going to do that. You could say, well, the reason to get your ACL reconstructed is to not tear your meniscus. That data is equivocal. There are plenty of studies that say there's no difference in downstream subsequent meniscal tears and reconstruction or non-reconstruction. There's been some more recent papers that say, yeah, there's a big jump in meniscal tears, especially if you're really young and active. But that data is, there's as much evidence on one side as the other. And so that's not really what we do know is long-term reconstruction doesn't prevent OA. I would say surgery shouldn't be the first option. It should be the last option. Rehab, go through the rehab, see how you function, see how you do. If you can function without repeated swelling episodes, repeating given ways, see how you do in your sport, go back. And I do think there is a cohort that is a real option. And if you say, well, that's not an option in, say, the NFL or NBA because everyone has their ACL reconstructed, that's not true.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.